Data published in the National Institutes of Health is raising awareness about how bipolar disorder shows up differently in Black patients. That data from a 10-year period found that compared to their white counterparts, Black patients with bipolar disorder get fewer of the medications that prevent future episodes and more medications typically used for schizophrenia. This would then lead to missed or delayed diagnoses. Researchers say that healthcare providers need to recognize those distinct patterns early through culturally appropriate screening. That means understanding the historical and cultural context of each patient's experiences. The findings also highlights partnering with trusted community organizations to reduce the stigma and building trust through open dialogue about treatment options. Speaking of which, in this weekend's conversation, I first asked a University of Michigan Health West psychiatrist how mistrust in the healthcare system affects when Black patients do need to seek help.
A lot can honestly impact that. I mean, in part, it could be generational narratives that are handed down by other family members that can limit individuals to seeking care in the first place because of what they've been told over time. Individuals in the Black population may also have more coercive means of accessing care if they're going more so through the legal system rather than the medical system to even initially access that care. It really just depends on how they're coming to us in the first place. Of course, there's also a lack of Black physicians across not just psychiatry, but across specialties, which also impacts how they might be perceived, what diagnoses they might be rendered, and what care they might get as a result. So there are a lot of barriers out there. Some issues are also just systemic in nature. I mean, there just aren't enough of us psychiatrists across this country to support everyone, let alone specific populations who might be more vulnerable and who need a different type of care that's more thoughtful.
Yeah, not enough representation for those in those practices to truly resonate with the individual battles that these patients might be facing.
And just to feel safe and to feel like they're in an environment that is free of stigma, bias, because that bias is still inherent. As much as we receive training to recognize it and to very much avoid it, inevitably it is probably still present.
How do you and your peers build trust with patients who've unfortunately had negative experiences in mental health care?
So a lot of that stems again from our training. A lot of us are trained to have a more cultural lens and a better understanding of some of the experiences these individuals might be bringing to the table, because even if someone is coming with a first break manic episode and they have bipolar diagnosis, ultimately we have to think back and look at the whole picture. We really need to start with their family's history actually, and then their own developmental trajectory, making sure there's no trauma component to their history. Other diagnoses, ADHD, I mean, it's never cut dry in one diagnosis. It's a whole human that's sitting in front of you. So you have to take into respect everything, not just the culture, but their socioeconomic status, all the factors that can be giving us a picture of what's in front of us.
Yeah, there's no cookie cutter answer to figuring out what's the best treatment for this one particular person, especially a person with their own experiences that are unique and individualistic to them.
And that is actually kind of on us. As clinicians, we really need to be thoughtful. Yes, something might present like schizophrenia initially, and we might start treatment, but we have to be mindful of whether or not the treatment is actually helping the individual, and sometimes go back and think back, maybe this was a bipolar disorder, and that does have implications for treatment, because we notice that individuals in the Black community, they are more so likely to be diagnosed with schizophrenia, and we know from more recent studies that really across ethnicities, cultures, bipolar disorder presents essentially pretty similarly. So why are these individuals being diagnosed more so with schizophrenia? And then that has implications again for treatment. They are more likely to then get an antipsychotic rather than a mood stabilizer like lithium. And that could change the whole trajectory of their prognosis.